Good morning, everyone, and welcome. This is Grace Lee, Chair of the Advisory Committee on Immunization Practices, and today is October 19th, 2022, and I'm pleased to call today's ACIP meeting to order. I am going to turn it over to Dr. Melinda Wharton to start the meeting with some logistics.
Good morning. Thank you, Dr. Lee. Next slide, please. Good morning, and welcome to the October 19th and 20th ACIP meeting. Copies of the slides being presented at today's meeting are available on the ACIP website or will be posted there soon. Additionally, we make slides available through a share file link for ACIP voting liaison and ex officio members. A few notes on meeting logistics for those who are listening in on the Zoom line. Please mute your lines at all times until you're called on for discussion. When Dr. Lee opens the meeting for discussion, please raise your hand. During the discussion period, Dr. Lee will take questions first from voting ACIP members and then from ex officio members and liaison representatives. We ask ACIP members to please not use their video except during votes. And next slide, please. The Advisory Committee on Immunization Practices is, at its heart, a public body, and engagement with the public and transparency in all our processes are vital to the committee's work. For this meeting, we will be holding 2 oral public comment periods. The first is scheduled for 3:30 p.m. Eastern today, October 19th, and the second is scheduled for 1 p.m. Eastern tomorrow, October 20th. To create a fairer and more efficient process for requesting to make an oral comment, we ask that people interested in making a comment submit a request online in advance of the meeting. Priority is given to these advance requests, and if more people request to speak than can be accommodated, we conduct a blind lottery to determine who the speakers will be. Speakers selected in the lottery for this meeting have been notified in advance of the meeting. Members of the public can also submit written public comments via regulations.gov using docket number ID CDC 2022-0111. Information on the written public comment process, including information on how to make a comment, can be found on the ACIP meeting website. Next slide, please. As noted in the ACIP Policies and Procedures Manual, members of the ACIP agree to forgo participation in certain activities related to vaccines during their tenure on the committee. For certain other interests that potentially enhance a member's expertise while serving on the committee, CDC may issue limited conflict of interest waivers. Members who conduct vaccine clinical trials or serve on data safety monitoring boards may present to the committee on matters related to those vaccines, but those members are prohibited from participating in committee votes on issues related to those vaccines. Regarding other vaccines of the concerned company, a member may participate in discussions with the provision that he or she abstains from all votes related to the vaccines of that company. At the beginning of each meeting, ACIP members state any conflicts of interest. Next slide. I'm very pleased to introduce a new member of ACIP, Dr. Nirav Shah, who is Director of the State of Maine Center for Disease Control and Prevention. He serves as the state health official for the state of Maine. He is recent past president of the Association of State and Territorial Health Officials. I believe he just finished his term. He's not, yes. Next slide, please. Just to share one bit of information about Dr. Shah, when he is not working, which I cannot imagine is not that much of the time, he does enjoy exploring Maine's beautiful outdoors with his dog, Quincy. Next slide, please. And with that, I will turn the floor over to Dr. Lee. Thank you.
Thank you, Dr. Wharton. And we wanted to take a few moments before we get started in our meeting today to share our gratitude for Dr. Kevin Alt. Dr. Kevin Alt has regularly attended ACIP meetings since 2004, and he became a member of ACIP in 2018. He served on our committee until the very last meeting, September 22, so just last month. And we did not have an opportunity to just recognize him for the work that he's done for the committee and just for his exemplary service, particularly during the COVID pandemic. During his tenure on our committee, Dr. Alt was chair of the ACIP Hepatitis Work Group, chair of the Combined Immunization Schedules Work Group, and a member of the Influenza Work Group, the HPV Work Group, and the COVID-19 Vaccine Safety Technical Pregnancy Work Group. And all of that has been incredibly impactful in terms of our deliberations. So as you know, his expertise in the delivery of care to pregnant women, and especially regarding vaccine use during pregnancy, has been tremendous, and I have personally learned a lot from him. You know, I do think his presence, just his very presence, has been impactful in making a difference to ensure that we're inclusive in our deliberations, inclusive of pregnant women, and always attentive to evaluating the impact of vaccines and vaccine recommendations in this population. So Dr. Alt, we wanted to make sure that we just took a moment to express our gratitude for your service to this committee, and wish you the best in your new role as chair of the Department of OBGYN at Western Michigan University Homer Stryker School of Medicine. So thank you, Dr. Alt, if you're listening. We really, again, appreciate your service, and hope we have a chance to connect with you again soon. And that is a picture of Dr. Alt there, sitting to the left in the middle of our committee table when we were able to meet in person.
In the before times.
In the before times, yes. And then this was also a picture that includes Dr. Alt and our committee members pre-COVID pandemic. So thank you again. And with that, we'll move on. Next, we'll go on to roll call. So for the ACIP members, I'm going to ask that you state your name, affiliation, and whether you have any conflicts of interest. And so today, we'll get started with Dr. Paling.
Good morning, Catherine Paling. I am a professor of pediatrics and epidemiology and prevention at Atrium Health Wake Forest Baptist, Wake Forest School of Medicine. I have no conflict. Thank you.
Thank you. Dr. Cineas.
Good morning. I'm Sybil Cineas. I am an internist and pediatrician, associate professor of medicine pediatrics at Warren Alpert Medical School of Brown University, and I have no conflicts.
Thank you. Dr. Cotton.
Good morning, Camille Cotton. I'm the clinical director of transplant and immunocompromised host infectious diseases at Massachusetts General Hospital and associate professor at Harvard Medical School. I have no conflicts of interest.
Thank you. Dr. Long.
Good morning. I'm Sarah Long. I'm a pediatric infectious disease doctor and professor of pediatrics at Drexel University College of Medicine in Philadelphia. I have no conflict to disclose.
Thank you. Dr. Shah.
Good morning, everyone. My name is Nirav Shah. As Dr. Wharton noted, I am the director of the State of Maine Center for Disease Control and Prevention, and I have no conflicts.
Thank you. Dr. Daly.
Good morning, Matt Daly. I'm a pediatrician and senior investigator at Kaiser Permanente, Colorado, also an associate professor of pediatrics, University of Colorado School of Medicine, no conflicts of interest.
Thank you. Dr. Brooks.
Good morning. Oliver Brooks, pediatrician, chief medical officer, Watts Healthcare Corporation in South Los Angeles, and I have no conflicts.
Thank you. Ms. Bata.
Good morning, Lynn Bata. I'm the immunization clinical consultant. I function through that as a public health nurse and with the Minnesota Department of Health, and I have no conflicts.
Thank you. Dr. Lair.
My name is Jamie Lair. I'm a practicing family physician in Ithaca, New York, and I have no conflicts.
Thank you. Dr. Chen.
Good morning, everyone. Wilbur Chen, professor of medicine and adult infectious disease physician at the Center for Vaccine Development and Global Health at the University of Maryland School of Medicine. I have no conflicts.
Thank you. Dr. Talbot.
Good morning. I'm Kip Talbot. I'm an associate professor of medicine and infectious diseases in the departments of medicine and health policy at Vanderbilt University Medical Center, and I have no conflicts.
Thank you. Dr. Bell.
Good morning. I'm Beth Bell. I'm a clinical professor in the Department of Global Health at the University of Washington, and I have no conflicts.
Thank you. Ms. McNally.
Good morning, Veronica McNally, President of the Franny Strong Foundation based in Michigan, and I have no conflicts.
Thank you. Dr. Sanchez? And we'll come back to Dr. Sanchez. And this is Grace Lee. I'm a professor of pediatrics at Stanford University School of Medicine, Associate CMO for Stanford Children's Health, and I have no conflicts. And for our committee today, we do have quorum, and we will call on Dr. Sanchez in a moment. For our ex officio and liaison members, I'll announce the organization name, and then please indicate if you are present and your first and last name. So very pleased to start with Centers for Disease Control and Prevention.
President Jose Romero, Director, National Center for Immunization and Respiratory Diseases.
Thank you, Dr. Romero. Centers for Medicare and Medicaid Services. We'll move on to Food and Drug Administration. Next, we'll move on to Health Resources and Services Administration.
Commander Reed Grimes, Director, Division of Injury Compensation Programs for HRSA.
Thank you. Indian Health Service.
Good morning. This is Dr. Matthew Clark, representing Indian Health Service.
Thank you. National Institutes of Health.
Good morning. John Weigel from the National Institute of Allergy and Infectious Disease.
Thank you. Office of Infectious Disease and HIV/AIDS Policy. We'll move on to our liaison representatives, the American Academy of Family Physicians.
Pamela Rockwell, AAFP, present.
Thank you. American Academy of Pediatrics.
Sean O'Leary, representing the AAP.
Thank you. American Academy of Pediatrics Red Book. American Academy of Physician Assistants.
Good morning, Marie-Michelle Léger, AAPA.
Thank you. American College Health Association.
Good morning, Sharon McMullen for ACHA.
Thank you. American College of Nurse Midwives.
Carol Hayes, present.
Thank you. American College of Obstetricians and Gynecologists. American College of Physicians.
Good morning, Dr. Jason Goldman, present.
Thank you. American Geriatric Society.
Morning, Ken Spader for AGS.
Morning. America's Health Insurance Plans.
Yeah, this is Bob Gluckman, President. I just would like to note this will be my last meeting. With the transition to in-person meetings coming, the travel schedule is just a little bit more than I can handle from where I live. And I just wanted to thank all the committee members and the professionalism of the CDC staff, and really enjoyed my time serving in this really critical time. So thank you.
Thank you, Dr. Gluckman, and thank you for letting us know. And we really, as always, have appreciated your service to this committee, and we look forward to working with whoever will be coming in as the liaison for AHIP. We'll move on to American Immunization Registry Association.
Good morning, Rebecca Coyle, representing ERA.
Thank you. American Medical Association. American Nurses Association.
Good morning, Chad Riddle, representing the ANA.
Thank you. American Osteopathic Association. American Pharmacists Association.
Good morning. This is Michael Hogue, representing the American Pharmacists Association.
Thank you. Association of Immunization Managers. Association for Prevention, Teaching, and Research.
Rick Zimmerman at the University of Pittsburgh, representing APTR.
Thank you. Association of State and Territorial Health Officials.
Hello, this is Kim Martin, and I'm representing ASTO.
Thank you. Biotechnology Innovation Organization.
Good morning, Phyllis Arthur, representing Bio.
Thank you. Council of State and Territorial Epidemiologists.
Chris Hahn, present for CSTE.
Thank you. Canadian National Advisory Committee on Immunization.
Good morning, it's Shelley Deeks from NACI.
Thank you. Good morning. Infectious Disease Society of America.
Good morning, Jim McCauley, IDSA.
I think you were a little muffled. I just want to confirm. Was that Jim McCauley?
Yeah, sorry, Jim McCauley, IDSA.
Thank you so much. Next, we'll move to International Society for Travel Medicine.
Good morning, Elizabeth Barnett here for ISTM.
Thank you. National Association of County and City Health Officials.
This is Matt Zahn representing NACHO, present.
Thank you. National Association of Pediatric Nurse Practitioners.
Good morning, Patsy Stinchfield representing NAPNAP.
Thank you. National Foundation for Infectious Diseases.
Good morning. This is Bill Schaffner on behalf of the NFID.
Thank you. National Medical Association.
Good morning. This is Dr. Michael Young on behalf of the NMA.
Thank you. Pediatric Infectious Disease Society.
Good morning. Evan Anderson on behalf of PIDS.
Thank you, Dr. Anderson. Pharmaceutical Research and Manufacturers of America.
Good morning. Corey Robertson, present.
Thank you. Society for Adolescent Health and Medicine. Society for Healthcare Epidemiology of America, although I think Dr. Dries did let us know she would be joining a little late. Okay. We'll go back up and ask if there are any other ex officio representatives or liaison representatives who did not have a chance to announce themselves. If you'd like to raise your hand, I'll call on you and you can please announce yourself. Thank you. Dr. Kim?
Well, good morning. Apologies for reporting in later than expected. This is David Kim with the Office of Infectious Disease and HIV/AIDS Policy in the Office of the Assistant Secretary for Health.
Thank you, Dr. Kim, and welcome. Anyone else? All right. Well, with that, we will move on to are there any other announcements, Dr. Warden? No? Okay, thank you. With that, we'll move on to our first session for the day. And our first session is the pneumococcal vaccines group, and we are so pleased to have Dr. Kathy Paling, who is chair of the pneumococcal work group, provide an introduction and an overview of today's session.
No.
Give us just one moment.
All right, good morning. I want to welcome everybody to the first work group on pneumococcal vaccines. I want to say a special thanks to my co-ACIP member, Dr. Sarah Long, our ex officio members, and a special thanks to our CDC lead, Moako Kobayashi. And then we have some really amazing and highly invested liaison representatives and consultants that have provided great insights. Next slide, please. As well as some great CDC contributors without whom we wouldn't be able to be here today. And a special thanks to our GRADE and ETR consultants as well. All right, so as a reminder, in 2021, 2 new pneumococcal conjugate vaccines were licensed for adults. It was the PCV15, which had 2 additional serotypes from the PCV13, and PCV20 with an additional 7. In addition, we still have PPSV23. All right, next slide, please. So the current adult recommendations for vaccines we've been working on and want to remind us on what we've previously done. So for adults over 65, 19 to 64 with chronic medical conditions, immunocompromising conditions, CSF leak, and cochlear implant, they are currently recommended to receive PCV20 or PCV 15 and followed by PPSV 23 if they've previously been unvaccinated. If you've only received PPSV 23, any adult with these indications more than 1 year later can receive either conjugate vaccines. All right, we'll move on. So here are persons who have previously received PCV 13 with or without PPSV 23 to complete their previously recommended series. So the recommendation is for those 19 to 64 CSF leak cochlear implants to, after the PCV 13, to receive PPSV 23, and then 5 years later receive one more dose at 65 years of age, at least 5 years after the previous dose. For PCV 13 only, 19 to 64 with immunocompromised, they've got the PPSV, 5 years later, PPSV 23, and then 5 years later, the final dose after 65 years of age. And then at 65 years of age, it depends on which group you're in as to how much time, but you get another PPSV 23. And for those that have received both a conjugate and a PPSV 23 after age 65, there's no additional recommendations. And so this has been a topic of conversation at many ACIP meetings. We've received lots of comments from the work group as well as from the public. And so we are tackling these issues. Next slide, please. So adults who were previously recommended to receive PPSV 23, if you have no if you're 16 to 24 years to 64 years of age, the cochlear implant, CSF leak, and immunocompromising conditions, you're recommended to receive PPSV 13 and PPSV 23 with repeat doses if you're immunocompromised. And then 65, we've got you're recommended to receive both. As shared, the previous recommendation was both vaccines with shared clinical decision-making, and then for the cochlear implant, CSF leak, and immunocompromised, you had both recommended fully. Next slide. So here are the policy questions that we are going to be tackling. There's 3 of them, and the next slide will break it down for us. If we could switch to the next slide. Okay, so the first 2 questions are really focused on adults who have started but not yet completed their pneumococcal vaccine series. The first question is focused on adults aged 19 and older who previously received the PCV 13 only and would have been recommended to receive PPSV 23. The second question is focused on adults 19 to 64 with an immunocompromising condition, CSF leak, or cochlear implant who previously received both PCV 13 and PPSV 23 and are recommended to receive another PPSV 23. And so the question is, should they be recommended to receive either PCV 20 to complete those series? Next slide, please. The third question that we tackled are adults who've completed the recommended pneumococcal vaccine series. They're over 65 years of age, and they've received both a conjugate and PPSV 23. And the question was, should they receive a dose of PCV 20? Next slide. The guiding principles that the work group has used throughout are the following 4. Decisions on policy options should be supported by best available evidence. Simplifying existing pneumococcal vaccine recommendations could help improve vaccine coverage among adults. Disparities in pneumococcal disease burden and vaccine coverage should be reduced, and timely recommendation for each new vaccine should be made after an FDA licensure. Next slide, please. We do want to provide a heads up that we have in June approved the PCV 15 use in children, and want to let everybody know PCV 20 is anticipated in Q2 2023. So that's going to be the focus of the pneumococcal work group after this meeting. Next slide, please. We also want to provide the context that there's additional pneumococcal conjugate vaccines, both a 24 and a 21, that are currently being studied. So this is going to be on the horizon. We don't have timeframes yet. Next slide. So today, we are going to have Dr. Charles Stoker share the cost-effectiveness analysis of PCV20 use among adults who previously received PCV13. And then we're going to follow that up with the CDC lead, Dr. Miyako Kobayashi, who's going to provide a summary of the work group interpretations of the evidence to recommendation and proposed recommendations, followed by proposed updates to clinical guidance on pneumococcal vaccine use among adults. With that, I want to say thank you.
Thank you so much, Dr. Paling. We'll move on to Dr. Charles Stoker from Tulane University. And can we please bring up his slides? Before we get started, I'm going to just ask if there are any additional individuals who've been able to join. But first, I'm going to call on Dr. Pablo Sanchez. Dr. Sanchez, if you could state your name, affiliation, and whether you have any conflicts of interest.
Thank you, Grace. This is Pablo Sanchez. I have no conflict, and I'm a neonatologist and pediatric infectious disease specialist at Nationwide Children's Hospital, The Ohio State University in Columbus, Ohio. Thank you.
Thank you, Dr. Sanchez. And are there any other individuals who would like to raise their virtual hand and announce themselves if you are a ex officio member or a liaison? Thank you. Ms. Howell.
Hi, this is Molly Howell, Immunization Director for the North Dakota Department of Health, representing AIM, the Association of Immunization Managers.
Thank you. Dr. Freihofer.
Sandra Freihofer, General Internal Medicine Physician in Atlanta, Adjunct Associate Professor of Medicine at Emory University, representing the American Medical Association.
Thank you. Okay, I do not see any additional hands raised, so we will plan to move on to our next speaker, Dr. Charles Stoker from Tulane University. If we could please bring his slides up, we'll get started.
Thank you.
Thank you.
My name is Charles Stoker. I'm from Tulane, and I'm going to be presenting the economic assessment of the 20-valent pneumococcal conjugate vaccine for adults that have previously been vaccinated with PCV13. Next slide. And I have no conflicts. Next slide. So the study question is going to be to evaluate the cost effectiveness of using PCV20 after PCV13 in adults. Next slide. And we're going to look at program costs and medical savings. We're going to track changes in disease, medical costs, and non-medical costs. We're going to look from the societal perspective, which means that we'll incorporate all relevant costs. The population is going to be cohorts of either 42 plus, 65 plus, or 75 plus year olds who have had PCV13. And we're going to separate model reports for the immunocompromised, those people with HIV, cancer, organ transplants, and dialysis, or the healthy and the chronic medical conditions populations. Those will be bundled together, but the two parts will be chronic medical conditions will be those with diabetes, heart disease, lung disease, liver disease, alcoholism, and everyone else will be healthy. Next slide. So the first question, the use of PCV20 in adults who previously received PCV13 only. For the model, we've looked at several different types of people. So you can see the 5 types of people there, just reading the first row, looking at the current, a population that has currently received PCV13 at age 65 in the healthy CMC population. And then we're looking at adding PCV20 at age 66, so 1 year later. That row is bolded because that's the analysis that we'll show some detail for later. But we also perform the other analyses with similar results, and we'll go through those very briefly. But the second row would be PCV13 at age 75, adding PCV20 at 76, so 1 year later, et cetera. Next slide. So the second question is the use of PCV20 in adults with immunocompromised who are not yet 64 years old, who previously received both PCV13 and PPSV23. And the one analysis that we'll focus on under this question will be the bolded one at the top there. Those who received PCV13 plus PPSV23 at age 42. We picked 42 because it's in the middle of this 19 to 64-year-old age range. And then adding PCV20 5 years later at age 47. Next slide. And then the last question is the use of PCV20 in adults age 65 plus who previously received PCV13 and PPSV23. So in this slide, it's those that do not have immunocompromising conditions, so the healthy CMC. And then the run that we'll focus on here is those that got PCV13 plus PPSV23 at ages 65 and 66, and then looking at adding PCV20 5 years later at age 71. Next slide. And this is just like the previous slide. We won't focus on any of these results, but we did do them, and we'll have a brief overview. But this is similar to the previous slide, but for adults with immunocompromising conditions after age 65. Next slide. So as I mentioned, we're going to use a cohort model. We're going to track cost per quality adjusted life year gained, cost per life year gained. The cohort sizes that we run through the model is going to depend on the age and the percent vaccinated with either PCV13 or PCV13 and PPSV23. So for example, the model size for, say, a cohort of 75-year-olds with immunocompromising conditions are going to be, the number of 75-year-olds with immunocompromising conditions times the percent that have been vaccinated with both of those doses. So in the model, the comparator will have a 100% vaccination rate in the PCV13 or the PCV13 plus PPSV23 as appropriate. And then we'll be looking at adding PCV20 onto these folks later. All outcomes are going to be discounted by 3%. We're going to adjust all prices to 2021. We're going to look 15 years ahead for the time horizon. We're going to compare incremental calculate the incremental cost effectiveness ratio. So we're going to divide the change in costs by the change in our summary metric is going to be quality adjusted life years. And we're also going to do a probabilistic sensitivity analysis. We're going to run the model 50,000 times. We're going to look at the cumulative distribution function of dollars per quality. We're going to look at the 5th and 95th percentiles, and we're going to do this tornado of all influential outputs, which I'll talk about more later. Next slide. So these are the health outcomes we'll track: cases of IPD, NPB, inpatient and outpatient, deaths due to IPB and NPP, QALYs, which is that summary measure that adds up all of those previous 5 health outcomes and life years. Next slide. This is the conceptual model. We start with a study population. There'll be 2 schedules, the schedule with and without PCV20, and then those are the outcomes that we track. Next slide. So the next few slides are all of the disease inputs in the model. So this is the community-acquired pneumonia hospitalization rates per 100,000. We get this from 2013 to 2015 data. And just the general setup here is we're going to have mostly different numbers for the healthy CMC and IC. And we're also going to have these numbers different for different age ranges. You can see them there. The healthy CMC, the healthy and the CMC populations below 64 aren't in the model. So those scores are blank. Next slide. And these are similarly the IPD rates, which we get from the ABC's data. Next slide. And the case fatality rates from similar data sources tracked separately for IPD in the first table and for non-invasive disease in the second table. Next slide. And then the serotype distributions. So a potentially pretty important part of the model is these folks have already been protected with PCV13. What are the additional protections they're going to get for PCV20? And we've broken it down by serotypes that are covered by PCV13, plus 6C, minus 3, minus 19F. We track serotype 3 separately because we think that the vaccines may work differently against that particular serotype. And 19F also for indirect reasons. And then PCV15 we track, PCV15 only types we track, and then PCV20 only types. In this model, obviously, PCV20 will hit both the PCV20 only types and the PCV15 types. And then we track the PPSV23 only types. And we do that separately for IPD, you can see in the top table, and for hospitalized all-cause pneumonia in the second table. Next slide. And this is the IPD data for the CMC population. Next slide. And this is those tables again for the immunocompromised population. Next slide. So the vaccine effectiveness numbers, the first column is going to be the healthy and CMC vaccine effectiveness numbers, and the last column is going to be the immunocompromised vaccine effectiveness numbers. So the top row there is the effectiveness of the conjugate vaccines, so that's both 13 and 20, versus vaccine type IPD. So it applies to the 13 types in PCV13 for PCV13, and the 20 types in PCV20 for PCV20. And you can see that the ICVEs are about a third of the healthy CMC VEs. And we assume similar rates for the healthy CMC, except if you'll skip down to rows 3 and 4, you can see that we assume slightly different numbers for the healthy, the effectiveness of the conjugate vaccine against vaccine type disease, except serotype 3 in the healthy of 66.7, and slightly lower vaccine effectiveness for the CMC population of 40.3. And then the bottom row there is bottom 2 rows of the effectiveness against the saccharide vaccine against vaccine type IPD for the saccharide vaccine. And you can see those numbers are lower than the conjugate vaccine. Next slide. So these are the cohort size modifiers, which I mentioned previously. So these are going to be based on the coverage data for PCV13 and PPSV23. So for instance, just looking at the top row there, so for a healthy cohort that is, where we're looking at whether they've, for the healthy cohort that has only previously received PCV13, that's going to represent about 13% of the age 65 plus cohort. So we're going to figure out how many healthy adults there are 65 plus, take 13% of that population, and that will be our starting cohort for any run that looks for the adding PCV20 to a population that had previously received only PCV13 in the healthy. And similarly for the other numbers in the table. And you can see some of them are quite small. For instance, the IC cohort that's received only PCV13 is about 3.1%, et cetera. Next slide. So in model coverage rates, as I've mentioned, PCV13 is 100% because we're already conditioned on the people that have received PCV13. PPSV23 is also 100% in scenarios that consider PPSV23. And then there's no scenarios where there's a coverage rate of PPSV23 that's not either 0 or 100% because we split those out into separate model runs. For adding PCV20 in cohorts less than 75 years old, we assign a coverage rate of 63.8%. And for a 75-year-old cohort, we assign a coverage rate of 72.7%. And the way that we obtain those numbers is looking at the ratio of the PPSV23 coverage to PCV13 coverage from CMS data. So the idea is this is about the rate that people go on to get the second vaccine in a series. So these people have already received either 1 or 2 doses previously in the series. So we'll just apply the same follow-up. Next slide. So for herd effects, we're going to apply the serotype group specific declines previously observed in PCV13 types in adults after PCV13 introduction in children. So we're anticipating that there will be a PCV15 recommendation starting in 2023 and a PCV20 recommendation starting in 2024. And we're going to apply the similar experience to what we saw for PCV13, but we'll also run the model with and without those. Next slide. For utility decrements, we need a way to add up all of these disparate endpoints. We display them here. So if you get a case of IPD, we track that and count that as a quality decrement of 0.07. You can see right there in the first cell. And we'll add up all of the cases of IPD that are prevented by adding PCV20, and then multiply that by the quality values of each thing that's prevented, add those up, and that will be the total quality adjusted life years that are saved by adding PCV20. Next slide. So for waning for PCV13 and for 20, we're going to assume no decline in the first 5 years and then a linear decline over the next 10 years. PPSV23 will decline similarly over 15 years, but slightly more aggressive at the start. Next slide. For vaccine price, you can see them there. We pull those from the maximum allowable Medicare reimbursement for the most part. The key one here is going to be the PCV20 number at just shy of $300 per dose. Next slide. Disease costs, we're going to track the costs of each hospitalization and an outpatient visit. And when PCV20 saves one of those, we'll add up those costs. Next slide. Okay, so we're starting the results. This is the first really detailed slide. So this is the highlighted run for question 1. And this run is, you can see at the top there, it's getting PCV13 at age 65. So the cohort already has PCV13, and then we're looking at adding PCV20 1 year later for this cohort. you can see the first column there is the base case. So in the base case, we prevent 97 cases of invasive pneumococcal disease, 343 cases of hospitalized pneumonia cases, et cetera, on down. The key number that I want you to focus on is the third to bottom number in that first column, which is the cost per QALY. That's the cost effectiveness ratio. So that adds up all the costs. So the extra amount that we spend on vaccines, the amount that we save on medical costs, and divides it by the QALYs. So the QALYs are that index way of adding up inpatient, outpatient cases. And we get $493,242 per quality adjusted life year. And then if you skip over to the next column, you can see the 5th and 95th percentiles from those 50,000 runs of the model. And we can see the ranges from 399,000 to 741,000. Next slide. We want a way to track which inputs the model is most sensitive to. So here you can see a tornado diagram. And the size of the bars indicate how sensitive the model is to that particular input. We start at the top of the tornado diagram with the widest bar. This is going to be the vaccine effectiveness of PCV versus PCV type pneumonia in the chronic medical condition population. This is a population that has really high disease rates. And we can see that the range of the cost effectiveness ratio at the end can be anywhere from 446,000 to 696,000. The way that we get those two numbers is we look at the cost effectiveness ratios when the VE versus PCV type pneumonia for the CMC population is in the bottom 10% or the top 10% of the distribution. So if the VE for the CMC population is in the top 10% of the distribution. So we sample this parameter randomly from the distribution specified on the vaccine effectiveness slide. If it's in the top 10% of those numbers, then the cost effectiveness ratio is as small as 446,000. And if it's in the bottom 10% of those numbers, then it's as large as 696,000. And this is the most influential parameter on the cost effectiveness ratio. They're organized in roughly decreasing order of influence. You can see the next one is the indirect effects from the childhood program. I'm only going to present one of these tornado diagrams. They're all going to look very similar. The most important thing is generally either the indirect effects from the childhood program or the effectiveness of PCV vaccines against non-invasive disease in the chronic medical condition population. Okay, next slide. So this is a cumulative distribution function for the same run as we saw before. Now this is breaking down that cost per quality number for the 50,000 iterations. It's the curve follows the number of simulated distributions, simulated runs that are below the indicated quality number. So none of the runs for this question were below $300,000 per quality. It just starts to pick up there a little bit after 300,000. And about 35% of the runs were below $500,000 per quality. And about 70% of the runs were below $600,000 per quality. So this gives you some sense as to what the numbers could be, because obviously we have uncertainty around all of the inputs, and this is a simple way to aggregate all of that uncertainty. Next slide. So this is the run that we want to highlight for question 2. So question 2 was looking at the immunocompromised population that had previously received PCV13 and PPSV 23. So for our representative run, we're going to look at a cohort that received PCV13 at age 42 and PPSV 23 at age 42, and then looking at adding for them PCV20 5 years later. You can see in the base case, we prevent 3 cases of invasive pneumococcal disease and 11 cases of hospitalized pneumonia cases, et cetera, on down. Now, these numbers are quite a bit smaller than the previous one because the cohort is quite a bit smaller. You can see at the bottom of the first column there's about 12,000 people in this immunocompromised cohort. But again, the thing that we want to focus on is that third to bottom number, the cost per quality, the cost effectiveness ratio. So that's going to be $254,555 in the base case. And your 5th and 95th percentiles are going to run from 179,000 to 493,000. Next slide. And similarly to the representative run for question 1, this is that cumulative distribution function for question 2. So for question 2, we can see that none of the runs cost below $100,000 per quality, but we've got about 50% of the runs that are below $300,000 per quality. So the distribution, it looks more cost effective than the previous one because it costs us less to pick up a quality for question 2. But you move to the right of that distribution, and we still have 20% of the runs that cost more than $400,000 per quality. Next slide, please. So this is the representative run for question 3. Question 3 was looking at adding PCV20 for adults 65 plus that had both PCV13 and PPSV23. So then the representative run, we're looking at PCV13 at 65, PPSV23 at age 66, and adding PCV20 5 years later at age 71. In the base case, we prevent 115,000 cases of invasive pneumococcal disease and 870 cases of hospitalized pneumonia. And then again, focusing in on that cost per quality, so that ratio of how much it costs us to pick up an extra quality adjusted life year, it costs us $414,166. And then the 5th and 95th percentiles are 281,000 to 872,000. Next slide. And this is that CDF for question 3. So just the previous run, but coming up with a way to summarize the uncertainty. None of the runs cost below $200,000 per quality. By the time we get to $300,000, we've got about 7% of the runs. About half of the runs are below $500,000 per quality, but about 20% of the runs are more than $800,000 per quality. All right, next slide. So we also do a bunch of one-way sensitivity analyses. So those previous results have been from a multivariate where we sample all of the distributions at the same time. Here, we're just going to turn off and on one of the assumptions. So the 2 assumptions we're going to turn off and on are, one is we're going to eliminate herd effects from the childhood program. And then the other one-way sensitivity we'll do is we'll assume that PCVs have 0 effectiveness against serotype 3. Next slide. So this is a summary graph of all of the models for all of the questions, just presented all at once. The red dots are the base case scenarios. So there'll be in each stack of 3 symbols will be one of the runs. For instance, at the far left, you can see a red dot kind of in the middle of a diamond and a triangle. So for that particular run, the base case is somewhere north of $100,000 per quality. And then the diamond says, okay, we're going to assume that there's no vaccine effectiveness against serotype 3. So then the cost per quality increases slightly. The diamond is a little bit higher than the red circle. And then in a different scenario, we're going to assume that there's no herd effects. So there, the triangle is going to be slightly below the circle. And if you just look at all of these 3 stacks, you'll see that the 2 one-way sensitivities don't really matter a whole lot. So especially assuming no vaccine effectiveness against serotype 3 doesn't really change things. It makes them slightly more inefficient, slightly more. It costs slightly more per each quality adjusted life year gain, but not a huge difference. And I would say similarly for assuming no herd effects. So if you don't believe there'll be a KID program or that there'll be any indirect effects from the KID program, then the triangles are where you'd want to look at, but those are not materially different from where the red circles are. Next slide. So these are the same runs, but now what I've done is I've highlighted the schedules that have a 1-year delay versus a 5 or 10-year delay. And we can see that the 1-year delay schedules are kind of like the range, right? So the one at the far left has a 1-year delay, and the one at the far right has a 1-year delay. So it's a little bit more complicated than just than whether it's a 1 or 5-year delay. Next slide. And then this is again the same runs. Each stack of 3 symbols is one particular run, and I've highlighted in red the schedules that add to PCV20 after age 65. So either adding at age 66, 1 year after receiving PCV13 age 65, or age 71, et cetera. And these are the ones that are more expensive. So the schedules where PCV20 isn't recommended until age 75, obviously it lines up a little bit better with the disease profile there, and those ones tend to be a little bit cheaper. Next slide. All right, so to sum up the limitations, we've got substantial uncertainty around effects from the childhood program. We've got uncertainty around vaccine effectiveness against non-invasive disease. Next slide. And we have no policies or model simulations below $126,000 per quality adjusted life year. It's important to put that into context. ACIP, of course, does not use a threshold for cost effectiveness ratios, but it is helpful to think about what other institutions use. So NICE uses 50,000 pounds per quality adjusted life year. One frequently cited threshold in the literature in America is $100,000 per quality to be considered cost effective. And then at kind of the top end, we have the statistical value of a life year, which is about what people would pay to get an extra year of life on little marginal safety improvements. And that's about maybe $500,000 per quality adjusted life year. So to summarize all of the questions, in question 1, that was adults 19 plus who previously received PCV 13 only. The cost effectiveness ratios for the base case range from $137,000 to $557,000 per quality. For question 2, this was about immunocompromised adults age 1964 who previously received both PCV 13 and PPSV 23. The quality adjusted life year, the cost per quality adjusted life year ranged from $255,000 to $341,000 per quality. And then for question 3, this is adults 65 plus who had previously received both 13 and 23. The cost effectiveness ratios range from $188,000 to $874,000 per quality in the base case. And then lastly, to bring these into context from recent PCV modeling for adults at age 65 plus. So the committee voted not so long ago on replacing PPSV 23 plus PCV 13 with PCV 20 for all, and that was cost saving, or replacing that pairing of 23 and 13 with 15 plus 23, and that was also cost saving. So cost saving means on net we save costs and we gain health outcomes, with contrast to all of the runs shown today where we spend money and we do get better health outcomes. And then lastly, the committee voted to not continue recommending PCV 13 for all in 2019. And that was based, at least in part, on a cost per quality of $562,000. And that's everything. Next slide. Thank you so much.
Thank you so much, Dr. Stecker, for that very thorough presentation. I am going to ask our committee members if they would like to ask any questions about this presentation, and if so, please, raise your hands. Oh, here we go. Dr. Shaw, please go ahead.
Thank you, Dr. Lee, and Dr. Stecker, thank you for this exceptionally clear and thorough analysis. I had a question that I just wanted to confirm my understanding on with respect to the conceptual model. I believe in the slides it was roundabout slide 12. I'll wait for it to come up.
Go ahead.
While it's coming up, my question was around the comparator scenarios. In the model, at least as it's displayed, one could get the impression that the comparator, say at node 1, was between someone on a schedule who receives either PCV 20 or no vaccination. When in fact, I think irrespective of our recommendation, whether we vote or not in favor of PCV 20, that individual would not receive no vaccination, but rather something adjunct, perhaps PCV 13. And so I wanted to get a sense from you of in your model, whether the comparator was the person who receives no vaccination or whether that person hypothetically gets some other vaccine known today.
I'm so sorry, your microphone cut out.
Maybe slide 12, or no, I guess, there it is, the conceptual model slide, that's it. So I'm looking at, for example, on node 1. Oh, and that's actually different from what, okay, got it. Yep. So they are vaccinated with PCV 20, and then the comparator in node 1 is unvaccinated, but presumably that person is not getting no vaccine. Presumably they are getting something that's just not PCV 20.
Can you hear me?
Yes, we can. Dr. Stecker, can you hear us in the room? Dr. Stecker, you might be muted. If you're able to unmute, that would be...
Okay, can you hear me?
Now we can, thank you.
I'm sorry, I didn't catch the end of the question. I'll answer the first part and stop there. The point is exactly correct. Everyone in this model has received PCV13 at minimum, and in several of the models, they've received PCV13 plus PPSV23. So that Schedule A versus Schedule B on the slide displayed now is whether we add PCV13, and then after they get Schedule A, they can either be, comply with the schedule, in which case, this is about 60 to 70% of the people get vaccinated with PCV20, or not comply with the schedule and not get vaccinated. So yes, everyone in the model already has a fair amount of protection against pneumococcal.
Understood. I don't, thank you. That's helpful. I think my question is going forward from the point at which so when your analysis picks up, it contemplates two scenarios. One is the scenario in which the person you described, who already has their prior vaccines on board, one scenario is the scenario under which they receive PCV20. And I believe in your model, the other scenario is a scenario under which they receive no subsequent vaccine. And I want to, and if that's the case, that's helpful. But my question is, really the question on the table is comparing the marginal benefit of PCV20 versus whatever the status quo would be. And I suspect in practice, the status quo is not no vaccine, but rather whatever the standard of care is today, which the infectious disease experts will confirm, I suspect, is something akin to PCV13. So I just want to make sure your analysis is setting up the answer to the right question, which is the comparison of the marginal benefit of PCV20, not to no vaccine, but rather to the status quo standard of care today.
Exactly, though. So if you can skip forward to slide 19, so that should be like 7 slides forward. Yeah, perfect. So, the standard of care is a little bit unclear. You can see that there's people in each of these buckets. Like some people get PCV13 only, some people get PCV13 plus 23, even though they're recommended to get 13 plus 23. So what the model does is it looks at what people actually got today of either PCV13 or PCV13 plus PPSV23, and looks at what it would do to add 20 to those particular populations. So yes, it's the marginal effect of adding 20 over a population that already had some protection.
Thank you very much.
So this is Grace Lee. I'm just want to clarify that answer, just so I understand it entirely. So it is a mixed population on which you're comparing this. So some of the individuals would have gotten PPSV, would have gotten nothing, and some of them would have gotten some vaccine. Is that right? So the comparison is against the current status quo, so against PPSV23, for example, for policy options 1 or 2. Okay.
No, there's no one in the model that has gotten nothing. Everyone in the model has gotten at least 13.
At least 13, but not completed their series.
Some have and some haven't. So you can see each of the buckets here, like for instance, in that top row, there are some runs where we look at the healthy population that received 13 only. And so that's 13% of the 65 plus and 15% of the 75 plus. And then there's some runs in the second row where they received 13 plus 23, and that's going to be 15 and 4% of this population.
And it's incremental to that. Thank you. Dr. Lear.
Thank you for your presentation. I'm still confused by, if someone could give me an example of a healthy person under 65 who would have gotten either PCV13 only or PCV13 and PPSV23, and I can't think of anything.
That's why those are missing, right? So the 42 plus, there's a dot there because there's no healthy people under 65 that are, we just didn't do a run for that, right? Because obviously those would be non-compliers.
So to follow
it starts
up,
at the 65 plus.
Excuse me, to follow up, for the policy question from the original, there's a question number 1, it talks about adults greater than 19 years who previously received PCV13, and I'm a little confused by that.
Dr. Kobayashi?
Oh, yes, thank you. This is Dr. Kobayashi. So yes, so the 19 years old and older who receive PCV13 only, so that includes adults 19 to 64 years old who are immunocompromised, or adults 65 years or older. So those are the groups who were previously recommended to receive PCV13 and PPSV23. So to clarify, no adult groups were recommended to receive PCV13 only. They were recommended to receive PCV13 in series with PPSV23. So that group who only received PCV13 are people who are in between the recommended series. They haven't completed it. And we included that because we know that even as of now, there are people who have only received PCV13 only.
Thank you.
Any additional questions? I mean, one thing I want to just point out from the slide that I think is really helpful to me is understanding that the proportion of people who are actually getting pneumococcal vaccine is extremely low. And so it does seem like we have a lot of work to do to actually just get people vaccinated, period. So we are focusing on a very small population. I was noticing in your presentation, you're estimating about 12,000 individuals each would be affected for policy option 1 and 2, and about 500,000 for policy option 3, as was written in the first presentation. Is that about right?
Oh, sorry.
No.
This is
Sorry, it's about 500,000 for 1 and 3, and then 12,000 for 2, because 2 is the immunocompromised.
Got it. Thank you. Dr. Paling.
And I'd just like to highlight, this is a time-limited period, because as we transition, this would go away. So it's how do we handle the transition?
Thank you. I don't see any other hands raised in the Zoom meeting. With that, why don't we go on to our next presentation. Thank you very much, Dr. Stucker, for that thorough presentation. We'll move on to Dr. Miwako Kobayashi, who will speak to us about the summary of the workgroup interpretation of the ETR and proposed recommendations. So we'll pull up her slides.
Good morning. On behalf of the workgroup, I will present the data and the workgroup's interpretation of PCV20 use among adults who previously received PCV13 using the evidence to recommendations framework. As a reminder, PCV20 contains the 13 serotypes in PCV13 in yellow and the 2 additional serotypes included in PCV15 in green and the 5 additional serotypes shown in blue. And PPSV23 contains 4 additional serotypes that are not included in PCV20, shown in orange. As a reminder, previously adults with an immunocompromising condition, cochlear implant, or cerebral spinal fluid were recommended to receive 1 dose of PCV13, followed by various doses of PPSV23, depending on underlying conditions and their age. In adults 65 years and older without these conditions were recommended to receive PPSV23 and PCV13 based on shared clinical decision-making. So no adult groups were recommended to receive PCV13 only. And here are the policy questions that Dr. Paling showed earlier. And so as a reminder, the first 2 groups, adults 19 years and older who received PCV13 only, whom I'll refer to this group as group 1, and then adults aged 19 to 64 years with an immunocompromising condition, cerebral spinal fluid leak, or cochlear implant who received both PCV13 and PPSV23, I'll refer to this group as group 2, are adults who have not completed their recommended pneumococcal vaccine series with PPSV23. So just to clarify the question earlier, so group 1 consists of adults who are immunocompromised, aged 19 to 64 years old, or adults 65 years and older who were previously recommended to receive both PCV13 and PPSV23, but somehow only received PCV13. Okay, so as a reminder, the recommended number of PPSV23 doses and the recommended interval for these adults vary depending on their age and underlying conditions. And once a dose of PPSV23 is given at or after 65 years, no additional pneumococcal vaccine doses are currently recommended. Therefore, the third group, adults 65 years and older who received both PCV13 and PPSV23, are adults who completed their vaccine series under current recommendations. So I will refer to this group as group 3. As a reminder, the ETR framework consists of the following 7 domains: public health problem, benefits and harms, values, acceptability, feasibility, resource use, and equity. First, public health problem. We will first look at the characteristics of the target population of the policy questions under consideration. The estimated number of adults 65 and older who have received at least one dose of PCV13 is 27 million, based on the population size and estimated PCV13 coverage. Among adults 19 to 64 years with immunocompromising conditions, data from market scans show that only about 5%, or 0.4 million people, received a dose of PCV13. In adults, pneumococcal pneumonia is the most common form of pneumococcal disease. Invasive pneumococcal disease, or IPD, defined as an illness with pneumococcus identified in a normally sterile place, such as blood or cerebral spinal fluid, is less frequent but a severe form of pneumococcal disease. In 2018 to 2019, the case fatality ratio from IPD among adults 65 and older was 14%. Younger adults have lower incidence of pneumococcal disease, but the risk is higher among those with immunocompromising conditions. This table shows the estimated incidence of hospitalized IPD and pneumococcal pneumonia by age group and risk group from an analysis using US healthcare claims data. And based on the rate ratio shown on the far right, adults with immunocompromising conditions have approximately 9 to 18 times higher incidence of pneumococcal disease compared with adults without underlying conditions. Next, we will look at the impact of PCV13 use against pneumococcal disease in adults. This figure shows the IPD incidence among adults 65 and older from 2007 to 2019. After introduction of PCV13 in children in 2010, we observed a decrease in the incidence of PCV13 type IPD shown in red. Please note that serotype 6C is assessed together with PCV13 serotypes in this figure due to cross-protection from serotype 6A, which is a PCV13 serotype. No additional declines in PCV13 type IPD were observed after routine PCV13 use was recommended for adults 65 and older in late 2014, and this trend continued through 2019. IPD incidence caused by serotypes not contained in PCV13, shown here in gold and black lines, has been stable. We'll now look at the trends of specific serotypes contained in PCV13 during 2011 to 2019. Among PCV13 serotypes, the incidence of IPD caused by serotype 3, shown in green in this figure, remained stable. In 2018 to 2019, serotype 3 caused more than 60% of the remaining IPD caused by PCV13 serotypes. So that is the reason why in Dr. Stecker's model earlier, we made some different estimates for VE against serotype 3. This graph shows the proportion of IPD by vaccine type for immunocompromised adults 19 to 64 years to the left, and all adults 65 and older to the right during 2018 to 2019. PCV13 types are shown on the bottom in light blue, and the 7 additional serotypes contained in PCV20 but not in PCV13, shown in orange and gray bars, caused 27% of IPD in adults. Now we will look at the impact of PCV13 use against pneumococcal pneumonia. This figure shows the incidence of hospitalized non-invasive pneumococcal pneumonia by adult age groups from CDC surveillance. From 2013 to 2014, before routine PCV13 was recommended for adults 65 years and older, hospitalized non-invasive pneumococcal pneumonia incidence decreased in all adult age groups. However, no further reductions were observed after 2014, including adults 65 and older, shown in gray. Reduction in hospitalized pneumococcal pneumonia due to PCV13 serotypes among adults 65 and older was observed in a Louisville cohort study from 2014 to 2016, when routine PCV13 use was recommended for this age group. Lastly, this figure shows the proportion of pneumococcal pneumonia caused by vaccine serotypes among adults hospitalized with community-acquired pneumonia from October 2013 to September 2016. The bar to the left is for 65 and older, and the bar to the right is for adults 18 to 64 with immunocompromising conditions. In this study, the additional serotypes included in PCV20, but not in PCV13, shown in gray, caused 3 to 4% of hospitalized community-acquired pneumonia cases. Next, we will look at the impact of the COVID-19 pandemic on pneumococcal disease incidence. This figure shows the IPD incidence due to all serotypes from 2014 to 2021 for adults 65 and older and for children under 5. In both age groups, the IPD incidence decreased in 2020 by 50% or more. In 2021, the incidence in older adults continued to decrease, while in children, the incidence increased, but not yet at the pre-pandemic baseline. This table summarizes data from an ongoing study of adults hospitalized with pneumonia. One hospital in Nashville collected data for 3 years before and during the pandemic. While there was an increase in the incidence of all-cause hospitalized pneumonia early in the pandemic, the incidence of pneumococcal pneumonia estimates decreased, as shown in blue. The workgroup determined that pneumococcal disease is of public health importance among adults who received PCV13. Vaccine-preventable pneumococcal disease burden remains, especially for pneumonia. Reduction in pneumococcal disease incidence due to COVID-19 is likely time-limited as reported in other countries. Adults in Group 1 have protection against limited serotypes. Adults in Group 2 may have limited protection from PPSV23, which we will review in the next section. And for Group 3, population size is substantial compared to the other groups, although some workgroup members believed that the significance depends on factors that determine the risk of pneumococcal disease, such as time since last vaccination, underlying conditions, or age. Next is benefits and harms. PCV13, PCV15, and PCV20 are conjugate vaccines, and the capsular polysaccharide antigens are conjugated to a carrier protein. This allows the conjugate vaccines to induce a T-cell dependent response, which confers immunity in young infants who do not respond well to polysaccharide vaccines. A T-cell dependent response also results in memory B cell production. So as a result, conjugate vaccines are expected to have longer duration of protection than polysaccharide vaccines. Effectiveness against IPD is supported by clinical data for both conjugate and polysaccharide vaccines, although limited effectiveness of PPSV23 has been reported in adults with immunocompromising conditions. PCV13 efficacy against vaccine-type non-invasive pneumococcal pneumonia was supported by a clinical trial, whereas data on PPSV23 effectiveness against this outcome have been variable. According to CMS unpublished data, in June 2022, the median time since last PCV13 vaccination among Medicare beneficiaries 65 and older, with or without PPSV23 receipt, was 5.6 years, ranging from 0 to 8.5 years. Among adults who received PCV13 followed by PPSV23, the median time since last PPSV23 vaccination was 3.1 years, ranging from 0 to 8.4 years. For grade, our population was US adults 19 to 64 years with an immunocompromising condition, cerebral spinal fluid leak or cochlear implant, or adults 65 years and older who previously received PCV13 with or without PPSV23. The intervention was 1 dose of PCV20 compared with use of PPSV23 based on currently recommended dosing and schedule. Outcomes were vaccine-type IPD, vaccine-type non-bacteremic pneumococcal pneumonia, vaccine-type pneumococcal disease mortality, and serious adverse events following vaccination. We searched PubMed to identify any published data on PCV20 efficacy, effectiveness, immunogenicity, or safety. In addition, we searched clinicaltrials.gov to identify additional PCV20 clinical trials. There were no PCV20 efficacy or effectiveness data. After excluding studies that targeted pneumococcal vaccine naive adults and studies that did not include the outcomes of interest, we identified 2 immunogenicity studies. One of them reported data on safety by previous pneumococcal vaccination status. Both were phase 3 clinical trials among adults 65 and older without immunocompromising conditions. The first study by Cannon assessed safety and immunogenicity of PCV20 use among adults who previously received PCV13 alone, PPSV23 alone, or PCV13 followed by PPSV23. The study did not compare the immunogenicity of PCV20 with PPSV23. Safety after PCV20 use compared with PPSV23 use was assessed in adults who previously received PCV13 only. The second study was a post hoc analysis of a clinical trial that assessed co-administration of PCV20 with a quadrivalent inactivated influenza vaccine. Response to PCV20 was stratified by previous pneumococcal vaccination status. Since there were no comparison of PCV20 and PPSV23 immunogenicity among previously vaccinated adults, we compared the immunogenicity of PCV20 based on previous vaccination status. Opsonophagocytic activity geometric mean titers, or OPA-GMT, which is a measure of functional antibody activity, 1 month after PCV20 vaccination were numerically higher among adults who previously received PCV13 only compared with those who received PPSV23 only. Similar trends were observed among those who previously received PCV13 followed by PPSV23 compared with those who received PPSV23 only. Percent seroresponders defined as percentage of participants with a 4-fold or greater rise in OPA titers from before to 1 month after PCV20 vaccination was numerically higher among adults who previously received PCV13 only compared with adults who received PPSV23 only for most serotypes. Compared with adults who previously received PCV13 and PPSV23 compared with PPSV23 only, percent seroresponders were numerically higher for only a few PCV20 serotypes. However, adults who previously received both PCV13 and PPSV23 tended to have higher titers at baseline compared with adults who received PPSV23 only. Among adults who previously received PCV13, serious adverse events, or SAEs, through 6 months after vaccination were similar across all groups. There were no vaccine-related SAEs, and there were no deaths reported. The work group determined that the desirable anticipated effects of PCV20 use were moderate for groups 1 and 2 and small to moderate for group 3. The work group's interpretation for the first 2 groups was based on the understanding of immunologic benefits of conjugate vaccines compared with polysaccharide vaccines, since these are adults who are currently recommended to complete their series with PPSV23. For adults in group 1, some believe that the benefits depend on the type of underlying risk of disease. For adults in group 3 who have completed the recommended series with both PCV13 and PPSV23, more workgroup members believed that the incremental benefits of PCV20 use will be smaller compared to the first 2 groups. Some workgroup members believed that these adults will still benefit from added serotype coverage by a conjugate vaccine, whereas others believed that the benefit would depend on factors such as time since vaccination, age of patient, presence of underlying medical conditions, or indirect effects from pediatric PCV20 vaccination. The undesirable anticipated effects of using PCV20 among previously vaccinated adults were considered to be minimal. The workgroup believed that the desirable effects from PCV20 use outweigh the undesirable effects given the minimal anticipated undesirable effects. Certainty of evidence was determined to be low for both effectiveness and safety for groups 1 and 2. For group 3, the certainty of evidence was determined to be moderate for both effectiveness and safety. For adults 65 and older, indirectness was downgraded once to serious for evidence of effectiveness, since we only have immunogenicity studies and correlates of protection have not been established for the critical outcomes. Imprecision was downgraded once for evidence on safety because of the very small size of the study population. For immunocompromised adults 19 to 64, certainty of evidence on effectiveness and safety was further downgraded for indirectness, since the included studies enrolled adults 65 and older without immunocompromising conditions. Next is values. The work group's interpretation was probably yes for the first question: do adults who previously received PCV13 feel that the desirable effects from PCV20 vaccination are large relative to undesirable effects? No research evidence was identified for this question. Since these are previously vaccinated adults, the work group believed that they are likely to have some understanding of the importance of receiving pneumococcal vaccines. Some work group members felt that there is not enough information to make the decision, or that interpretation will vary among the target population. For the second question, is there important uncertainty about or variability in how much adults value the main outcomes? The work group's interpretation was probably not important uncertainty or variability for groups 1 and 2, since these are previously vaccinated adults. Whereas the work group's interpretation for group 3 was variable. Since these are adults who completed the recommended vaccine series, some work group members believed that there could be uncertainty or variability depending on factors such as their age, life expectancy, time since last vaccination, or perceived severity of pneumococcal disease. Next is acceptability. We reviewed data from 2 healthcare provider web-based surveys for this domain. The first survey by Pfizer showed that 65% or more of the respondents agreed to the use of a higher valent pneumococcal conjugate vaccine for prior PCV13 recipients. In the second survey by the University of Iowa, respondents were asked whether providers agreed with providing PCV20 for previously vaccinated adults. Respondents agreed the most to administering PCV20 for immunocompromised adults 19 to 64 who previously received PCV13 only, and the least for adults 65 and older who received both PCV13 and PPSV23. The work group's interpretation of acceptability was probably yes for all 3 groups. Next is resource use. Evidence for this domain was based on cost-effectiveness analyses conducted by 3 modeling groups at CDC, Merck, and Pfizer. These summary slides are based on the work by Dr. Andrew Leiners at CDC's Immunization Services Division. And here are the conflicts of interest statements. This figure shows the size of the population by age and previous vaccination status. In adults 65 and older without immunocompromising conditions who received both PCV13 and PPSV23, shown in dark gray, had the largest population size. Therefore, the comparison will focus on assessment of PCV20 use among adults 65 and older who previously received both PCV13 and PPSV23 and therefore completed the recommended vaccine series. This table summarizes the differences in key assumptions across the models. The blue cells are assumptions that can decrease the incremental cost-effectiveness ratios, or ICERs, meaning that PCV20 use can become more favorable from an economic perspective. CDC and Pfizer's models considered indirect effects from pediatric vaccination, whereas Merck's model did not assuming indirect effects can decrease ICERs because indirect effects decrease vaccine-preventable disease burden among adults. Pfizer's model assumed higher effectiveness of PCV against remaining serotype 3 disease compared to the other 2 models, and assumed that PPSV23 has no effectiveness against non-bacteremic pneumococcal pneumonia. These assumptions can decrease ICERs compared with the other models. Assuming more severe outcomes from pneumococcal disease, such as higher case fatality ratio from inpatient pneumococcal pneumonia that was used in the Merck model, or assuming a larger quality-adjusted life year or quality losses from disease, as assumed in the Pfizer model, can decrease the ICERs. This table summarizes the averted disease burden of PCV20 use among adults 65 and older who received both PCV13 and PPSV23, compared with no additional vaccination. To make the findings comparable, all findings are from single cohort models of adults aged 71 to 73 years. Time since last vaccination ranges from 5 to 7 years. and all models showed that health outcomes in yellow rows improved with PCV20 use compared with no vaccination. Estimated deaths, hospitalizations, and cases averted in the Pfizer model in pink cells were not discounted. And as we saw in the previous slide, differences in estimated health outcomes are likely due to differences in model assumptions. This shows the range of cost per quality gained in the three models. CDC models estimates include results from a cohort that received PCV20 at age 71 and 81 years. And Pfizer's model resulted in the lowest estimates, and Merck's model resulted within the range of the CDC estimates. And Dr. Stecker mentioned this in his presentation as well, but to put these numbers in context, here are the cost-effectiveness ratios from previous pneumococcal vaccine policy questions among adults 65 and older. When continuing routine PCV13 use in series with PPSV23 was discussed in 2019, the cost per quality gained in the base case was $562,000 in the CDC model and $199,000 in the Pfizer model. Use of PCV20 or PCV15 in series with PPSV23 in previously unvaccinated adults was cost-saving in most scenarios when the policy option was discussed last year. For group 1, the most frequently selected response by the work group was yes, but some members selected probably no and no. Workgroup members believed that the benefits of recommending PCV20 still outweighed the cost for adults who have received PCV13 only, whereas some believed that the cost-effectiveness analysis findings do not justify the use of resources except for the immunocompromised. For adults who received both PCV13 and PPSV23, the workgroup's interpretation varied. For group 2, there were similar numbers who responded probably no, probably yes, or yes. For group 3, the most frequently selected response was probably no, but there were similar numbers who responded probably yes or yes combined. Those who responded yes or probably yes valued the anticipated benefits from PCV20 use over cost. Those who responded probably no believed that the anticipated added benefits from recommending PCV20 instead of PPSV23 for adults who have already received PCV13 and PPSV23 were not large enough to justify the use of resources. There were some who thought that the interpretation will vary depending on time since last vaccination, age, and underlying conditions. Next is equity. This figure shows US IPD incidence in Black adults in pink and white adults in light blue from 2008 to 2019. Since PCV13 was introduced in children, IPD incidence due to all serotypes decreased in all age groups. Racial disparities in PCV13 type IPD incidence in Black versus white adults reduced in all age groups. Although the incidence due to non-PCV13 serotypes remained fairly stable, Black adults continued to have higher incidence compared with white adults. This table summarizes any pneumococcal vaccine coverage among adults 19 to 64 with risk-based pneumococcal vaccine indication in 2019 to 2020 by race and ethnicity. This includes adults with chronic medical conditions such as diabetes, chronic heart and lung disease who were not previously recommended to receive pneumococcal conjugate vaccine. Hispanic and Asian adults had significantly lower vaccine coverage compared with white adults. This slide summarizes coverage of at least one dose of PCV13 and both PCV13 and PPSV23 in orange among Medicare Part A and B beneficiaries 65 and older. Compared to white adults, other racial and ethnic groups had lower coverage of PCV13 or PCV13 and PPSV23. The workgroup's interpretation of health equity varied for all three groups and was divided between probably reduced and probably no impact. The workgroup comments were following. Those who believed that PCV20 use would increase health equity felt that conditions that increase the risk of pneumococcal disease are more prevalent in non-white populations. PCV20 use will decrease remaining disparities in pneumococcal disease burden. And access to vaccines is likely better for minority populations compared with access to care for the disease. Those who believe that PCV20 use will probably have no impact on health equity felt that vaccine access and utilization are likely to follow existing patterns. There will be limited impact at the population level due to the small number of adults 19 to 64 with immunocompromising conditions who received both PCV13 and PPSV23. And the incremental benefits of PCV20 use will be small among adults who already received PCV13 and PPSV23. Some believe that equity will be reduced since PCV20 uptake will likely be higher among those with good access to care and could worsen existing disparities. Last domain is feasibility. The work group's interpretation for groups 1 and 2 was yes. Currently, the number of recommended PPSV23 doses and the recommended interval for these adults vary. So if a single dose of PCV20 can be used to complete the vaccine series, this may simplify the recommendations and may reduce the need to determine the patient's vaccination status. And it may also reduce the need to stock multiple types of vaccines. For group 3, the work group's interpretation was probably yes. These are adults who have completed the recommended vaccine series. So some work group members believe that adding a dose of PCV20 may complicate the recommendation. And compliance with the recommendation was also a concern for this group. Additional considerations include access to PCV20. According to a poll among members of the Association of Immunization Managers in September 22, members from 7 of 22 jurisdictions responded that they currently offer PCV20 through their adult immunization program. Under the Affordable Care Act, new ACIP recommendations are required to be covered starting 1 year after the date of the recommendation is issued, so PCV20 doses may not be covered by private insurance right away. This is a summary of the workgroup interpretation of the ETR domains. For the 2 groups that have not completed the recommended vaccine series, more workgroup members believe that the added benefit of PCV20 will be greater compared with adults in group 3 who have completed the recommended vaccine series. Also, more workgroup members believe that the intervention will be feasible for groups 1 and 2, as we discussed earlier. There was more variability in the workgroup's interpretation regarding PCV20 use for group 3. The workgroup believed that the added benefit will depend on factors that increase group 3's risk of pneumococcal disease, such as time since last vaccination, age, and underlying conditions. Regarding resource use, there were more workgroup members who believed that PCV20 use in adults who previously received PCV13 only is a good use of resources, whereas the workgroup's interpretation was variable for the 2 groups that received both PCV13 and PPSV23. Overall, the workgroup believed that the desirable consequences probably outweigh undesirable consequences in most settings when PCV20 is recommended for the 3 groups we considered. Before introducing the proposed policy options, I'd like to thank the committee, the pneumococcal vaccines workgroup, and the following individuals for their contributions. Now I will present the proposed policy options for ACIP members to consider. First option, adults who have received PCV13 only are recommended to receive a dose of PCV20 at least 1 year later after the PCV13 dose, or PPSV23 as previously recommended to complete their pneumococcal vaccine series. Second option, adults with an immunocompromising condition, cochlear implant, or cerebral spinal fluid leak who have received both PCV13 and PPSV23 before age 65 years with incomplete vaccination status are recommended to receive a dose of PCV20 at least 5 years after the last pneumococcal vaccine dose, or PPSV23 as previously recommended to complete their pneumococcal vaccine series. Third option, shared clinical decision-making is recommended regarding administration of PCV20 for adults aged 65 years and older who completed their vaccine series with both PCV13 and PPSV23. If a decision to administer PCV20 is made, a dose of PCV20 is recommended at least 5 years after the last pneumococcal vaccine dose. That is at the end of my presentation, and I'd be happy to take any questions.
Thank you. Before we get started, with questions, I believe we have a representative from Merck who would like to make a statement. Dr. Haupt, are you on the phone?
I'm here. Can you hear me, Dr. Lee?
We can. Please go ahead.
Yeah, thank you very much. Good morning. It's Rick Haupt. I head the Infectious Diseases and Vaccines Medical Affairs organization for Merck, and thank you for letting me address the ACIP. We really appreciate the commitment to the thorough evidence-based evaluation of available policy options for the use of the new pneumoconjugate vaccines for adults. I think we could see from today's discussions, it's a challenging question and really underscores the importance of considering the public health value of recommendations for new PCVs as an option for adults who've previously been vaccinated with PCV13 and or PPSV23. I think the evaluation today demonstrated there are some health benefits afforded by what I'll call catch-up vaccination. However, these potential benefits come at a high cost and would require a significant investment of resources. Thus, it's really important to consider the value of such an investment. I think it was already noted this morning, given that adult vaccination rates remain below optimal levels in general, perhaps a more effective use of resources should be applied to increase the proportion of unvaccinated adults, particularly in those socioeconomic groups that have disparities. It's important for us to note that PPSV23 remains the pneumococcal vaccine with the broadest serotype coverage, with demonstrated effectiveness against both invasive pneumococcal disease and non-bacteremic pneumococcal pneumonia. Revaccination with PPSV23 is immunogenic and well tolerated, resulting in long-term antibody levels similar to those achieved after primary vaccination. Thus, in this rapidly changing adult pneumococcal vaccination ecosystem, PPSV23 remains a good option to complete a series in those who receive PCV13. Just want to note that considering only PCV20 in this policy scenario does potentially lead to some unintended bias and creates potential de facto preferential recommendations for PCV20. So we appreciate that the policy options do consider PPSV23 as well as an option, and that's very important because preferential recommendations typically require a very strong clinical benefit profile and strong clinical evidence demonstrating significant impact on disease burden. And those were relevant a year ago when the recommendation for use of PCV20 or PCV15 plus PPSV23 in adults greater than 65 was considered. All those considerations are still relevant in today's discussion. So thank you for your time. Really appreciate it.
Thank you, Dr. Haupt, and thank you for keeping it brief. We really appreciate that. We'll move on to questions, first from our committee members, and if there are any from our liaisons afterwards. We'll start with Dr. Talbot.
Hey, I am so glad to see this being considered today. I love seeing our adults get the most up-to-date care possible. And this has been a big question, and I've gotten lots of emails about it, and I appreciate the feedback. I have a couple thoughts and a couple questions. No, mostly thoughts. So I would like to keep the pneumococcal vaccine recommendations as simple as possible. I also would like to make it efficient, and I would like to make it as up-to-date to give the best care possible to older adults. And so in my mind, if you have not received a higher valent conjugate vaccine, you should be recommended, not a physician discussion, but you should be recommended to receive a higher valent pneumococcal vaccine. It should not be shared clinical decision. And I think that will make it easy for the providers. It's just a yes. It's, have you received the most up-to-date? And they're used to this because every year, have you received the flu vaccine? So the question would be, have you received PCV20, yes or no? And I think that's it. I'm babbling now. Thanks.
Thank you, Dr. Talbot. Dr. Lear.
So thank you to everyone. I find it helpful to go patient by patient. And so I'm trying to, in my head, work around who's going to be getting these. So the first policy question is people 19 years and older who've received PCV13. So that's going to be the 65-year-old who's gotten PCV13 but hasn't gotten PPSV23 yet, or the immunocompromised who's gotten PCV13 and hasn't gotten PPSV23 yet. So that's 2 people. Question 3 is the 65-year-old who's gotten both vaccines already. Should we be giving them an extra PCV20 at this time? And the middle is immunocompromised who's gotten their first PCV13, their PPSV23, but 5 years later needs their second PPSV23. Should we give them the PCV20? So that helps me sort of figure out who I'm working with. And it sort of comes down to, in this transition, should we change over PCV20 for PPSV23? And I guess my question to answer that, I'm thinking out loud, is how much better is PCV20 than PPSV23? And it seems to me that it's marginally better. There are benefits, but it's also fairly costly. And that's the trade-off that I'm wrestling with in my own head. And so saying that out loud helps me think. I haven't decided how to vote yet, but it helps me think about which direction I'm going. So thank you.
Thank you, Dr. Lear. Dr. Brooks?
I think, first of all, Dr. Talbot's thought of having it be simple is maybe beyond the pale on this particular vaccine or these questions. And if you can pull that one off, Kip, I'm impressed. First, can we go to slide 70? I'm just curious about that slide. It was in equity. It was showing African Americans with non-PCV13. It was a graph. It's marked 70. And, yeah. It's non-PCV13, I think 2 slides forward here. So is this saying that African Americans are more likely to get or be hospitalized with non-PCV13 serotypes? I guess that's what it's saying. And so if that's so, I mean, does that mean that it would be better to have a vaccine that has the more serotypes in it? So I'm just trying to wrap my arms around that. I also noted that African Americans had the same level of vaccination, but things like this with higher rates. So in the equity domain, I have some questions. The greatest effect on IPD was when children got vaccinated. And we're looking at bringing on a vaccine, perhaps for children, to PCV 15 or 20 in the next year or so, maybe year or 2. So I'm wondering if that's where the real effect is going to come in. And then lastly, just a question, it was in the CE slides. There was a $500,000 quality for PCV 13 in 2019 that was voted down. Am I correct about that? So that's almost to me like a baseline in terms of when we look at quality, because I think with this particular vaccine, quality is really more important than any other vaccine I've evaluated thus far. So, I mean, on balance, I'm just really not sure how to put this all together. It's almost like we need a summary of the summary. I will say there was a lot of information presented, and there are a lot of different angles to this. And I think that the 3 questions, though, was a good way to kind of break it down in terms of what we will be voting on, at least evaluating. And I'll stop there. And Dr. Talbot, like I said, making it simple is the most challenging part of this to me.
I'm trying. I keep trying.
Thank you. Dr. Kobayashi.
Yes, thank you very much for that comment. I'll just make a quick comment about the equity epi data. So yes, you're correct. So unfortunately, there has been differences in the IPD incidence if you look at the data by race, and then the differences seen in the PCV13 types decreased. But then as a result, the remaining differences are largely driven by the serotypes that are not included in PCV13. Yes, so I wanted to make that comment. Thank you.
Dr. Long?
Being on this work group, I think I said for the first 20 or 18 meetings, I had a terrible headache at the end of the meeting because this is difficult stuff. It's amazing that you've picked up all these nuances, and thanks to the wonderful analysis and information in the way that both Kathy and Milwaukee have presented it, you've got the clearest picture there is. And it's very unusual for work groups, I think, to not settle on a single answer. And you see, we rarely settled on a single answer. And it wasn't, I reminded Kathy, because we were a problematic group. Because the problem was a real problem and the answer is not clear. And I think and we had practitioners on the group, Dr. Talbot, who just said, you've got to make it simple, you got to make it simple. And it certainly would be simple to say, at least everybody 65 and older should receive a high-valent pneumococcal conjugate vaccine. That would be the easiest. However, the differences of opinion really, I think, came down to what you bring to the table on how willing you are to spend other people's money and resources for this relatively small benefit in that 65 and older group. And we looked at things shorter than 5 years, and they were outrageously not cost effective. So that becomes the first time in which it might be something approachable. So a difficult decision for y'all, not so much about is there any benefit, but how much benefit for how much resource utilization and cost.
Thank you, Dr. Long, and the y'all includes you as well. So, Dr. Cotton.
I'd just like to speak in favor of the additional vaccine for immunocompromised patients. We definitely know that immunocompromised patients who, as in the slide, are 9 to 18 times more likely to have invasive pneumococcal disease, really have waning immunity over time. And so I think additional doses of vaccine seem likely to be protective, well-tolerated. And with respect to Dr. Talbot's point about enhanced clarity, I think that targeted education of different groups would be really useful, for clinicians who take care of immunocompromised patients. Hopefully the CDC and others, Merck is on the call. It seems that we do need a lot more education. It's really disappointing, even after decades of Pneumovax being available, how few American adults are vaccinated against a well-tolerated, with a well-tolerated vaccine against a common illness. So I just appreciate the attention for the immunocompromised hosts who still remain excessively vulnerable. Thank you.
Thank you, Dr. Cotton. And Dr. Shaw?
Thanks, Dr. Lee. One observation and then one question for Dr. Kobayashi. In connection with Dr. Talbot's points about simplification, which I completely concur with, I'll add that another benefit with respect to simplification is that which is faced by clinicians and office practices in only having to stock one vaccine. So inventory management becomes that much easier. The same applies for the state health departments that include pneumococcal vaccine as part of their vaccine for adults programs. There too, inventory management becomes much more streamlined. My question is for Dr. Kobayashi. Much like Dr. Ware, throughout the morning I've been trying to assess the marginal epidemiological benefit of the PCV20, and I note that Dr. Kobayashi, in your presentation, there were two slides. One was around slide 21 or so, and then the other was around slide 24, both of which purport to show the percentage of pneumonia that is accounted for by serotypes. The first one is a couple slides back, I think. Yep, so this one shows the percentage of pneumonia that is accounted for by serotypes contained in PCV20, but not PCV13. It comes in.
Invasive.
Oh, okay, got it. This is invasive, and then the other is just all cause. Is that correct? Yep, okay, very good. And so that shows us roughly the marginal epidemiological benefit of the PCV20 versus just the PCV13. Okay, thank you.
Thank you, Dr. Lair.
Just to clarify for myself, under these new proposals, we still be recommending PPSV 23 for adults 19 to 64 with chronic medical conditions but not immunocompromised conditions. So if that's true, I'm still going to need to stock extra vaccines. Thank you. I see nods, so that was agreed, yes.
Thank you. I have been listening and trying to integrate the aspects of this conversation. So, and I will state, I will go on to our liaison comments after this, and we'll go on to think about a vote language shortly after that. A couple of things. So one is regarding the use of PCV20 to complete a PPSV, to complete a series that would otherwise include the polysaccharide vaccine. I mean, I personally think that the potential for hyporesponsiveness to subsequent vaccines and the durability of immunity, so the immunologic sort of reasons, are a reasonable reason to move forward, regardless of the cost effectiveness estimates that we saw. In addition, it's a small proportion of individuals, so I'm thinking 12,000 people. So from that perspective, I think the total cost is actually much lower, and the cost effectiveness isn't as relevant to me. I'll also just advocate for the immunocompromised population, that I think that for them, there is benefit of getting a conjugate vaccine, and then the simplicity argument, I think, takes precedence. Regarding the policy, actually, Dr. Kobayashi, can you put up the 3 policy options? The third one, I just want to make sure we're anchoring on the same thing, which is the revaccination question in my mind is people who are not recommended to receive an additional set of vaccines. The question is really, should we offer revaccination or catch-up vaccination, however you want to phrase it? And I have to say I'm struggling with that. So I was trying to understand whether it was an access question, an acceptability question, or a complexity of recommendations question. And it feels to me like we've had access to these vaccines for many years, and it really seems to rest with, I'm assuming it's not acceptability, but really the complexity of our recommendations as they stand now. So I am trying to figure out if that language up there actually makes it more confusing or less confusing for clinicians who are trying to deliver vaccines. And so that's my struggle. I worry less about I think that access, I'm very comfortable with, we should provide access, but if it's going to add to the confusion of the currently existing recommendations, I guess I have some concerns. The other thing I'll say is that the benefits, based on the data that was presented today, are fairly limited from a population level perspective, as Dr. Shah pointed out. So while there could be theoretical individual benefit, I'm not seeing the population level benefit. And then one point of clarification, the cost effectiveness work that was done with pre-pandemic estimates, not during the pandemic where the numbers went down?
Yes, that's correct, Dr. Lee. We used pre-pandemic disease incidence data.
Okay, so then in my mind, the cost effectiveness will look worse in this context. And overall, I would say the most impactful thing we can do is probably think about vaccinating children. We saw that the impact of herd immunity was huge with the pneumococcal conjugate vaccines when they were introduced, and the direct recommendation of vaccination of older adults has not had as substantial an impact. I also am like a little bit confused about the health equity aspect of things, partly because we've talked a lot about this with COVID vaccines, which is that the 65 and older population tends to be predominantly white. And then I think we have a lot of uninsured and underinsured adults for where we have gaps. So I'm actually worried it might worsen existing gaps potentially. So although we are talking about the 65 and older population, so presumably Medicare would be the payer of choice. So I am struggling with this because I want to both provide access, but I also feel like this is a transient benefit that might increase complexity for our poor providers who are trying to vaccinate against COVID and flu in the coming season. I'm going to call on our liaison. Are there any other questions from members? Dr. Talbot?
Just a quick comment. When we do these cost effectiveness models, we look at hospitalizations and doctor's visits. What we don't look at is an older adult who's been hospitalized for pneumonia who never makes it back home, or who makes it back home and requires a large amount of support from home health and family members. And we do not take into effect the amount of time and money that family members must put in to take care of loved ones. I think it's really important to know that cost effectiveness models are good but limited. In older adults, we would like to compress the time of disability, and these vaccines, even if it's only a marginal benefit, can reduce that time of disability and provide improved life. And we cannot capture that in our cost effectiveness models. So providing the most up-to-date care limits that time of disability and provides meaningful life to large numbers of American adults. Thank you.
Thanks, and I'm just going to respond briefly, Dr. Talbot. So I wholeheartedly agree with you that we need a better, we need a very robust and comprehensive program to protect, especially I think our older adult and immunocompromised population against respiratory infections, both viral and bacterial. So I certainly think that is important. I'm still struggling with, is this the answer that's going to solve the problem? I think we need something much bigger and broader. So I don't disagree. And I don't always think cost effectiveness is the answer. I'm just struggling with this particular question. Dr. Long?
Yes, in reference to the anticipation of recommendation for children, the PCV13 had much less indirect effect on adults than did the PCV7. And we really don't know what 20 would do. So as Dr. Bell in Seattle has taught me, you can only deal with the vaccines in front of you. So I think we could, if there was a dramatic effect of immunizing children on adults, we can relook at this recommendation. But I don't think we should consider that at this point.
Thank you, Dr. Long. Dr. Paling?
I wanted to thank everybody for the very thoughtful questions and comments. This is hard and also really important. One of the things I wanted to do is respond directly to Dr. Lair and to Dr. Shaw. All the proposed language has either PCV20 or PPSV23, and that's really important because people can be holding PCV15 and 23 in their clinics, or they can be having PCV20, and that way everybody has an ability to, if this is approved, to participate without having to hold yet another vaccine. And then the goal for the immunocompromised and for the chronic medical conditions was to try to simplify and make them more similar than different for the ease of providers.
Thank you. Dr. Long?
It seems before we get to the motion for a vote, we should duke it out a little bit better about the may versus should. Because
gonna
that,
clarify,
I think,
it's
is
gonna
the
be
crux. And the may influenced a little bit of the equity question because we thought the mays would probably allow the more affluent population to get PCV 20. And so that's why we really thought our policy question was likely to be may, and it affected the equity. If it was should, I think that would be less likely to decrease equity or increase inequity, less likely. Too many negatives, but would be better if it was a should for everybody than if it were a may.
Thank you. Okay, I'm going to take a couple more questions, and we're going to go to our liaisons to make any comments or ask any questions, and then I think we're going to bring this back to discussing the vote language, and I promise we will continue to have discussions. We won't go to the vote prematurely. Dr. Lair.
I just want to reemphasize, as a practicing physician buying these vaccines, the rule is the insurance companies don't have to pay for it for a year after approval. My office still cannot give PCV 15 to many of the children because the insurance companies won't pay for it. And so that is something also to take into account. So it's a year from when the ACIP approved it, and so some of my insurance companies have not yet started covering the PCV 15 for children.
All right, thank you. And I see actually Dr. Gluckman has raised his hand, so maybe I'll let Dr. Gluckman go ahead first.
Okay, thank you. First of all, just wanted to compliment the committee on the robust nature of the conversation today. This is a complex issue. And as you consider this, I think it's important that ACIP recognizes how much power they have due to the mandate, so that when decisions are made, they do have significant implications for what must get administered and the cost of those. We have seen examples where the pharmaceutical industry was kind of compelled to lower costs based on ICER recommendations. The specific example I'd give was PCSK9 inhibitors for lowering cholesterol. And I don't know if there would be consideration for the committee to do an ICER-like analysis to determine what the cost of the product should be to meet a reasonable cost-effectiveness threshold, to put the appropriate pressures on the pharmaceutical industry to have rational pricing. I think that type of power does make it possible to have more effective and efficient use of resources, because Medicare resources are limited. So that's one thing I would ask the committee to consider, is the power of their recommendation, and to consider looking at what would the price need to be in an ICER type analysis to get a reasonable cost effectiveness threshold. The second issue, I've just been kind of fascinated to listen about the issues around the complexity and the stocking, because one of the things we're seeing in the community among providers is the complexity of just having to choose between PCV 20 versus PCV 15 plus PPSV 23, which the two vaccine combo does raise complexity because people need to come back in a year. And I don't recall from previous conversations if anybody's ever looked at the cost effectiveness comparisons between PCV 20 and PCV 15 plus PPSV 23. I do know that from a raw cost perspective, the combination is quite a bit more expensive. And again, turning to the power of the mandate, we're forced to potentially cover a vaccine schedule that is more complex and more costly versus one that might be simpler. And the current recommendation does add complexity and probable significant cost. Although I don't know what the uptake yet. I think we're seeing mostly PCV 20 being used in the community. So those are my comments, and thank you very much.
Thank you, Dr. Gluckman. Dr. Kobayashi?
Thank you, Dr. Lee. So yes, thank you for your comment. So regarding your question about direct comparison of PCV20 versus PCV15 and PPSV23, when we reviewed the evidence last year, we did not do any direct comparison. We reviewed both use of both vaccines compared to the previous recommendation, and that was because there were really limited data that provided direct comparison of PCV15 versus PPSV23. There were no immunogenicity studies that provided direct comparison. So therefore, the committee or the work group decided to review evidence separately for those two vaccines, and therefore we have an option for use of both vaccines right now.
It might be reasonable to revisit this at some later date as data becomes more available, just as you revisited the PCV13 recommendation for older adults at a later date. It does get back to the my comment earlier about the power of ACIP mandates. And so as we go forward, I think that there is an opportunity in the future to reconsider whether the complexity and the combination of the two vaccines is really worth it.
Thank you so much. We'll move on to Dr. Goldman.
Thank you so much. I struggle with this as well on the work group, but I always go by the patient in front of me. And while it is so important to look at cost to the public health, my concern as a practicing physician is what is best for that patient in front of me. And to Dr. Talbot's point, I kind of look at this as a catch-up vaccine. They have not received a higher valent conjugate vaccine, which seems to be more effective than a lower valent, hopefully, is the goal immunogenically. So I would err more on the side of giving them the PCV20 in order to make sure they have that appropriate coverage. And to Dr. Shah's point, who made it before I did, the importance of inventory management. As a practicing physician, it is extremely expensive to purchase these vaccines up front. We do not have a vaccine for adults program like they have for children. We have to pre-purchase them. We have to stock them. And to simplify it with giving one vaccine as opposed to multiple types of vaccines for the same disease makes it much easier when we're just using one simplified recommendation. I won't even give a plug for an age-based as opposed to a risk-based. But that being said, it's unconscionable to me that the insurance companies are posting billions of dollars in profit, yet they can't implement these recommendations timely, greater than up to 1 year. Some of them do it earlier, some of them have still waited. So it puts us in the community at extreme financial risk, and that decreases access because we can't get the vaccines timely to our patients with assurance of reimbursement to make sure they can be covered and paid for when the insurances just completely will not pay for them until a certain arbitrary time. So the simplification of carrying one vaccine to be stocked to benefit that patient and reduce harm when there's minimal risk, to me, is the simplest to go with these proposed recommendations from the work group. Thank you.
Thank you. Dr. Schmader?
Thank you. Regarding the shared decision-making recommendation for PCV20 administration to older adults who've completed both PCV13 and PPSV23, AGS just wants to go on record that this shared decision-making recommendation is problematic. It's simply not pragmatic in our settings, busy clinical settings with older adults with multiple chronic conditions, competing demands, oftentimes caregivers having to make decisions. And we know it did not work before when we had this with PCV13. So I guess I'm saying we completely agree with Dr. Talbot to simplify the recommendation. Thank you.
Thank you. Dr. Freihofer?
Sandra Freihofer, practicing a physician. I'm a liaison for the American Medical Association, but I'm speaking as a practicing physician. The complexity of the pneumococcal vaccination is certainly a problem for practicing physicians, and as mentioned by several other speakers, having to keep several different types of pneumococcal vaccines in stock in order to appropriately vaccinate patients. It's also very expensive and very difficult and puts a strain, especially on small practices. That said, I want to commend our speakers today for doing such a fabulous job of explaining the difference between the conjugate vaccines and the polysaccharide vaccines. I am very sensitive to increasing coverage by those different serotypes and appreciate that we now have a vaccine that covers more serotypes. It is a conjugate vaccine. But I have to say that the three recommendations that have been put up for a vote, to me, don't make this vaccination recommendation simpler. It adds complexity and confusion. And I too, like previous speakers have mentioned, look forward to seeing data in which children are vaccinated with these higher valent vaccines to see what effect that has on adults. But if we start vaccinating adults now, we may not know if that does exist. But it's been a very interesting presentation, and appreciate all the detail that the work group went through in presenting this information. Thank you.
Thank you. We'll take two more questions, Dr. Hoag and then Dr. Young. So Dr. Hoag, please go ahead.
Thank you, Dr. Lee. First of all, thank you to all of the presenters. Fascinating presentations, and I appreciate greatly the tremendous effort and work that was put into the detail. I am a pharmacist and am speaking on behalf of the American Pharmacists Association in that we also find significant problem with this recommendation that's on the screen relative to shared clinical decision-making in people who are 65 years of age and older. Increasingly, Americans have during the pandemic and now subsequently as we begin to think ahead, are getting their vaccines, adults particularly are getting their vaccines in pharmacies. Unfortunately, insufficient access in many community pharmacies today to the complex and complete medical records of patients makes it somewhat difficult and very time consuming to get into conversations from time to time with patients about which vaccines they may need when a shared clinical decision-making recommendation is put out there. And then secondly, it puts people, I think not just pharmacists, but all healthcare providers are faced with the ethical dilemma of the individual patient who is in front of you. And if you know you could give that patient something that would provide at least some more protection against a few more serotypes in the years where they're likely to be most vulnerable, their older years, against these infections, how could you possibly deny or not give that person the vaccine? So while I understand the population level cost effectiveness data and the potential marginal benefit, it seems difficult to put our healthcare practitioners, whether they're pharmacists, physicians, nurse practitioners, or others, in the position of trying to make, oh, well, yes, this makes sense. For you, no, this doesn't make sense. It's hard to withhold. I think that could actually contribute. In fact, the shared clinical decision-making could actually contribute to worsening health equity issues because shared clinical decision-making recommendations, as we've seen previously with pneumococcal recommendations from a few years ago, tend to cause providers to not do anything. And we didn't see immunization rates go up. In fact, we saw increased vaccine hesitancy. And if providers are confused about the recommendations, then patients will be too. So I really would urge the committee and the voting members to simplify this one, the one that's on the screen here. I have less problem with the other two that were shown previous slide. This one is very problematic for us and for me.
Thank you. And last question to Dr. Young.
Yes, I've had the unfortunate encounter to deal with this particular issue myself as a consumer. At 69 years of age, I presented to my local pharmacy, as the gentleman spoke to before. And I have both coverage with Blue Cross and Medicare. Blue Cross through my husband's insurance. And they battled. Essentially, Medicare said Blue Cross should cover some, and Blue Cross said no, Medicare should carry it all, and refused either of them to cover. So I either had to go in my pocket for that $247 or defer to see another route for this pneumococcal vaccine. So I'm a consumer looking at this from that standpoint, and it's so complicated. I was stunned, actually, that I chose PCV 20 because I wanted the conjugate with longer lasting, and I had only had PCV 13 many years ago, and no coverage offered by the insurance company at all, or Medicare. So I'm this dilemma. I see why there's a dilemma. So I'm glad I'm sitting at this process, but I do wonder, in a health equity standpoint, how others who are less have less capability are going to dive through this when insurance companies have the authority to deny like that for such a serious condition.
Thank you so much for your comments. We're going to move on to the to see if we can get a motion on the table. So, Dr. Kobayashi, are there? Oh, you've already pulled it up for us. Thank you. Somebody did. Is this the vote language as you would like, as a work group would like to propose it? Yes. Okay. So on the slide here, adults who have received PCV13 only are recommended to receive a dose of PCV20 at least 1 year after the PCV13 dose, or PPSV23 as previously recommended to complete their pneumococcal vaccine series. Dr. Lara, you have your hand raised?
Yes. I'd actually like to suggest splitting this into two different groups. One group is over 65, and one group is the immunocompromised. In my mind, I have them as two different categories. And so I would say that an immunocompromised would be, I can give language if necessary, but that's how I would think about it. So what you've got as policy number 2, which is coming up, I would put some of this under policy number 2, and I'd have some of this as adults over 65 who have only received PCV13. But I would be voting differently on those two categories.
Okay, so we don't have a motion on the table yet, so we can't really amend the motion if I've got my Roberts rules correct. But Dr. Kobayashi, I'm wondering if you can respond about the intent of this recommendation, just so we are all clear about what we're voting on.
Sure, absolutely. So basically, I understand that this covers different groups that I presented today, but either way, this adult only received PCV13 only and hasn't received any dose of PPSV23. So they have the least serotype coverage. So the intent of this vote is to offer an option to receive PCV20 to complete their recommended series.
So I thank you, and I recognize that, and I personally would vote differently if they were over 65 versus immunocompromised. So that's why I'm suggesting this as an option.
Dr. Romero.
So I believe this appears to be an amendment to what you're saying, but it's not. Is that we need clarification on that. Are you asking for an amendment to this? So and if it hasn't been mentioned by the chair that this hasn't been motioned yet. So is this still discussion?
So this is still discussion. I would change the language before we make a motion. This is just my suggestion, and I could come up with language pretty quickly, but this is a suggestion because I make the distinction between immunocompromised and over 65. And if other people don't agree with it, that's fine.
How about this? How about we?
I move to accept this I move to accept what's printed on the on what's shown on the screen.
Dr. Brooks has made a motion. Do we have a second? Dr. Cotton, please go ahead.
No, I second the motion.
Thank you. So it's been moved and seconded, and so now I think the question is whether or not there would be a modification to this. Let me just ask, Dr. Wharton, would you prefer to take that discussion to the actual vote section and discuss proposed modifications there, or would you like us to discuss it now?
It probably would be good to get it done now, if we could.
Why don't we get the second vote on the table? Because I think once we have all three motions up, then I'll have some more clarity to Dr. Lair about how to think about what your suggestion is. So actually, Dr. Kobayashi, would you read the second proposed vote on the table?
Sure, absolutely. Adults with an immunocompromising condition, cochlear implant, or cerebral spinal fluid leak who have received both PCV13 and PPSV23 before age 65 years with incomplete vaccination status are recommended to receive a dose of PCV20 at least 5 years after the last pneumococcal vaccine dose, or PPSV23 as previously recommended to complete their pneumococcal vaccine series.
Do I have any members who would like to make a motion?
I make a motion to accept, to propose this, accept this as written.
Okay, so Dr. Lair has moved to accept this proposed vote number 2. Do I have a second?
Second.
Thank you, Dr. Long. It's been moved and seconded to move this forward as a vote. Let us look at the third vote language. This is actually really helpful. Thank you. And Dr. Kobayashi, could you please read the third vote?
Shared clinical decision-making is recommended regarding administration of PCV20 for adults aged 65 years and older who completed their vaccine series with both PCV13 and PPSV23. If a decision to administer PCV20 is made, a dose of PCV20 is recommended at least 5 years after the last pneumococcal vaccine dose.
I move to accept because I think Robert's rules, we must do that before we amend.
Apologies?
A move to accept so that we can further discuss and consider an amendment.
Thank you. So Dr. Long has moved to accept this proposed vote number 3. Dr. Talbot?
I second, and I'm excited about altering it.
Okay, so we have 3 sort of large votes on the table that are somewhat complex in nature. What I'm going to suggest is that we come back to the discussion about any proposed amendments, because I think what I would like to do is just to give Dr. Paling and Dr. Kobayashi just a few moments to be able to reflect on this and come back with cleaner language. So we will come back to this discussion. What I'd like to do now is, now that we have 3 motions on the table, we'll move to the clinical considerations conversation and then hopefully come back to this discussion in a moment.
Okay. Okay, in this presentation, I will show the proposed changes to the current pneumococcal vaccine recommendations to provide clarifications and to address existing gaps for feedback from the committee. So this will not be part of the vote. So as a reminder, this is the current recommendation. So last year, ACIP recommended use of either PCV20 alone or PCV15 in series with PPSV23 for all adults aged 65 years and older, and for adults aged 19 to 64 years with certain underlying medical conditions or other risk factors who have not previously received PCV or whose previous vaccination history is unknown. And when the MMWR was published, we had a recommendation for adults who received PPSV23 only, which says adults who have only received PPSV23 may receive a PCV, either PCV20 or PCV15, at least 1 year after their last PPSV23 dose. And when PCV15 is used in those with history of PPSV23 receipt, it need not be followed by another dose of PPSV23. So here are the questions that we have received over the past few months related to these recommendations, which include, does who have not previously received PCV include adults who previously received PCV7? Wouldn't adults who received PPSV23 only be part of adults who have not previously received PCV or whose vaccination history is unknown? If an adult inadvertently received PPSV23 first instead of PCV15 for the series, is it a may or a should for a person to complete the series with PCV15? If an adult under 65 years with indications receives both PCV15 and PPSV23, does the person need another dose of PPSV23 in the future? And what should we do if we do not have access to PCV15 or PCV20? So to address these questions, here are the proposed updates to the existing language in red. So I apologize, the slide is a bit busy. But for the first recommendation, PCV, the proposed change is to specify to PCV13, PCV15, or PCV20 to be more specific. And also adding to complete the recommended vaccine series after when PCV15 is used, it should be followed by a dose of PPSV23 to clarify that additional PPSV23 doses are currently not recommended for these adults who get the PCV15 and PPSV23 series. Also, for the second bullet, I'm sorry, still the first bullet. So also the proposed change is to add, if PPSV23 is inadvertently given before PCV15, a dose of PCV15 or PCV20 should be given at least 1 year later to be consistent with the recommendations for adults who receive PPSV23 only, shown below. And also to address the issue of people who do not have access to PCV15 and PCV20, and there have been quite a few inquiries about this. The proposal is to add a footnote saying if PCV15 or PCV20 is not available, a dose of PCV13 may be given, followed by a dose of PPSV23 as previously recommended. For the recommendation for adults who receive PPSV23 only, we propose to change may receive a PCV to are recommended to receive a dose of either PCV20 or PCV15. And the rationale for these changes include, for example, for PCV7 recipients, it's been at least 10 years since PCV7 was available in the US, and we have a PCV that cover at least 8 or more pneumococcal serotypes, and the work group is currently proposing consideration of use of PCV20 for adults who previously received PCV13, so the changes were considered to make sense. And then in terms of not recommending additional doses of PPSV23 for adults who received PCV15 followed by PPSV23, healthcare providers have been confused by the recommendations of repeat PPSV23 doses. And as we saw in the earlier presentation, reported coverage of PCV13 and PPSV23 among adults aged 19 to 64 years with immunocompromising conditions. So these are the groups who are currently recommended to receive the repeat PPSV23 doses. But unfortunately, coverage in this group has been very low. And so it's more from the feasibility perspective. And then unknown impact of new PCV use in children. And new pneumococcal vaccines are in advanced stages of development, as Dr. Paling showed in her presentation. So I'm going to skip over this slide, which I showed earlier. And continuing on with the rationale. So the rationale for recommending PCV15 or PCV20 for adults who inadvertently receive PPSV23 first for the PCV15 PPSV23 series include, first of all, there was a suggestion to avoid use of should versus may. And also, it will allow us to harmonize the recommendation for adults who only receive PPSV23 only. And we have also similar recommendations for PCV and PCV13 and PPSV23 series. We say that if PPSV23 is inadvertently given, it should be followed by PCV13. And then recommending either PCV15 or PCV20 for adults who have received PPSV23 only. So as a reminder, we used to say may, but now that we are recommending PCVs for all adults with indications under the new recommendations, we are proposing to change the may to recommend it for everybody. The interval will not change. And the second piece of the proposed updates is to address a gap that we currently have, which is recommendations for adults who are hematopoietic stem cell transplant recipients. So as you may know, this is the table that we use to summarize the medical conditions or risk factors that have risk-based indications. And adults who have received hematopoietic stem cell transplants are not included as part of the pneumococcal risk conditions. But we do have existing guidance. So one is CDC's general best practice guidelines for immunization. So in that guidance document, we do have a language stating that sequential administration of 3 doses of pneumococcal conjugate vaccine is recommended beginning 3 to 6 months after the transplant, followed by a dose of PPSV23. And then the subsequent bullet talks about the possible schedule that can be used in this population. And then the second is IDSA's clinical practice guideline for vaccination of the immunocompromised host. So it says 3 doses of PCV13 should be administered to adults and children starting 3 to 6 months after hematopoietic stem cell transplant recipient. At 12 months after hematopoietic stem cell transplant, 1 dose of PPSV23 should be given provided the patient does not have chronic GVHD. For patients with chronic GVHD, a 4th dose of PCV13 can be given at 12 months after hematopoietic stem cell transplant recipient. So to reflect this, to address this gap, we propose to include a language that recommends PCV use in adults who are hematopoietic stem cell transplant recipients. So this is a proposed language. Adults who are hematopoietic stem cell transplant recipients are recommended to receive 3 doses of PCV20 4 weeks apart, starting 3 months after HSCT. This should be followed by a 4th PCV20 dose at least 6 months after the 3rd PCV20 dose, or at least 12 months after HSCT, whichever is later. And HSCT recipients who have started their pneumococcal vaccine series with PCV13 or PCV15 may complete their 4-dose pneumococcal vaccine series with PCV20. If PCV20 is not available, 3 doses of PCV15 4 weeks apart, followed by a dose of PPSV23 at least 12 months after HSCT may be given. For patients with chronic graft versus host disease, a 4th dose of PCV15 can be given in place of PPSV23. And the rationale of recommending use of PCV20 among this population is that we know that this population have poor immune response to PPSV23 when given during the first year of transplantation or longer, potentially, especially in those with chronic graft versus host disease. So therefore, the existing language does not recommend PPSV23 use within the first year of the receipt of the transplant. And we know that PCV20 currently has the broadest serotype coverage among available PCVs. And in this high-risk population, a regimen that provides broad pneumococcal serotype coverage early on is warranted. So we did look at evidence on PCV use, 4 doses of PCV use among this population. There are no PCV20 studies among HSCT recipients, but there are 2 studies that assessed use of 4 PCV13 doses. Both studies used 3 PCV13 series, followed by a booster dose 6 months after the 3rd PCV dose, and a dose of PPSV23, either 1 or 2 months after the final 4th PCV dose. And immune responses against the PCV13 serotypes increased from baseline to after the 3rd PCV13 dose, and from after the 3rd dose to after the 4th dose. And in one study, local and systemic reactions occurred more frequently after the 4th PCV13 dose compared with after 1st and 3rd dose of PCV13, but most were mild to moderate reactions. So these are figures from the 2 studies that I mentioned, showing the immunogenicity study results that I just mentioned. So basically, the response after 3rd dose is higher than the baseline, but then compared to the 3rd dose, the 4th dose is even higher. And this is from another study, essentially showing the same similar findings. And this is showing the reactions after receiving 1, 2, and 3, 4 doses of PCV13 that was shown in one study. So basically, the reactogenicity is higher after dose 4 of PCV. There is evidence on PCV15 use among HSCT recipients. It's a phase 3 randomized control trial among HSCT recipients. Participants received 3 doses of PCV, either PCV13 or PCV15, followed by a dose of PPSV23 at 12 months, or PCV in those who've developed graft versus host disease. And the summary of the findings is that immunogenicity was generally comparable for the 13 shared PCV13 serotypes between the PCV13 and PCV15 group. PCV15 recipients had higher immunogenicity for 2 additional serotypes not included in PCV13, and injection site adverse events and solicited systemic events were reported more frequently among those who received PCV15, but most were mild to moderate. So those are the summary of the proposed changes to the existing recommendations, and to one update to include recommendations for HSCT recipients.
Thank you. Thank you. Dr. Cotton, and then Dr. Long, do you have your hand raised? No. Okay, Dr. Cotton.
I'm so sorry.
Thank you very much for those changes. That will be extremely helpful to the stem cell transplant community. I do say that this kind of treats them as a homogeneous population, but in fact, people who undergo hematopoietic stem cell transplant could either have auto or allogeneic, and then allogeneic may or may not have graft versus host disease, may not be on immunosuppression, and is at higher risk for infection. I think starting fairly soon after transplant may be not so useful for some. I mean, I think it was starting 3 months after transplant. It could be quite quick, although it might be appropriate for auto, but not allo. I think adding the phrase that is in the COVID-19 recommendations may be helpful, that where it says a patient's clinical team is best positioned to determine the degree of immunocompromise, need for vaccination and appropriate timing of vaccination might be useful for clinicians. I get a lot of feedback, like this 3-month thing. Often at 3 months, people really are not having a robust immune response to vaccination. So I think that would give some clinician decision-making that would not be in the shared decision-making where we worry that people wouldn't get it, but would just allow clinicians, say, to move this to, say, starting 6 months after transplant to provide the vaccines. Thank you.
Thank you. Other comments or questions for Dr. Kobayashi? Okay, thank you so much, Dr. Kobayashi and Dr. Paling. You've given us a lot to think about. What we're going to do is we're going to take a, can I give us 10 minutes? Is that okay? 10-minute break. And we're going to come back to our next session, but we will have this further discussion around the vote language for clarification when we get to the votes later this afternoon. Thank you, everyone.